So, sir, we are starting now.
Yes.
So, may I have your attention, the esteemed faculties and delegates? I would now like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the localization assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event hosted by the National Neurology Forum, Gujarat State Chapter. And the focus of today's session is lessons from expert total parental nutrition. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahir sir to start the event today with his enlightening words and for the further coordination. So, over to you, sir. Kindly proceed.
Yeah. Thank you, Ritu. So today, as we have planned to do preterm nutrition in this in this month, so we have an esteemed faculty with us, Dr. Srinivas sir. We welcome you, sir. And
Thank
we
you, sir.
request Dr. Shwetal ma'am, who is the president of NNF Gujarat, to say a few words.
Thank you, Dr. Kunal. Good afternoon, sir. It's
Good
our
afternoon.
pleasure to have you on the NNF Gujarat academic platform. You are stalwart in field of neonatology, and I'm sure my students will be benefited from your session. This is the most important session as we more and more preterm we are saving. So preterm and the other morbidities where we may require sometimes a TPN. In that case, there will be really a very good important session, learning session for our students, postgraduate students. Thank you, sir, for accepting our invitation and being with us.
Thank you. I think, first of all, I should say thank you to Gujarat NNF, led by Shwetal and Kunal, past president, and the next president, advisors, Mohit Saini sir, giving me this opportunity to talk to the youngsters, the upcoming stars in the future, about the total parental nutrition. So thank you very much, Gujarat NNF, for giving this permission. Thank you.
Sir,
Shall I?
our EB member, Dr. Monish sir, will share your
Yeah, Monisha,
feathers
yeah,
on your
he's
cap.
going to be the
Yes.
moderator. Yeah,
Yes,
yeah,
yes, yes.
yeah.
Just
Thank you, sir. Welcome,
Thank
sir.
you. Yeah.
Welcome, sir. Dr. Srinivas, sir, I will just introduce you, sir. Sir is a government experience of 34 years. He has established 83 SNCU and NICU in Tamil Nadu, which is brought down to our IMR to the 13 per thousand. He has established 28 pediatric resuscitation emergency units in the district hospital with 6-bedded mini PICUs. With the foresight of sir to improve the survival of very low birth weight and early low birth weight babies. Under the innovation scheme, he introduced the PCV13 vaccine throughout the state, which has brought down the pneumonia deaths. Initiated the first SNCU at the tribal area at PSC, Udarnadu. CSC level established in 6 NRC nutritional rehabilitation centers in Tamil Nadu. Since 2012, introducing KMC at the SNCU levels. Sir has also in the newborn, he has introduced the newborn tracking scheme in the name of Chelapelli, was introduced in the Trichy district. Instrumental in government agenda of introducing 36 human milk bank in the state. Also, sir has worked as the state nodal officer for the corona and the dengue during the crisis. Best doctor award in the state during the 2017. Tamil Nadu Medical Council awarded in 2021 for tackling corona research on pneumococcal vaccine, assigning NPC of the pneumococcal strains in very low birth weight babies. Sir is a national trainer in IM, NCMI, FIMNCI, and KMC, State NNF Secretary and also a President. Excellent mentor for undergraduate and postgraduate. Sir is dias for you, and we will. Yeah.
Thank you for your kind introduction, sir. Can you share the slides, sir, Kunal, sir?
Yes, sir.
Yeah. So, good morning, all of you. I think this is one of the what Shwetal said that sometimes we use. I say that sometimes should go year after. It should be all time for all the VLBW and ELBW babies to come. So, sir, let's go to the first slide, sir. First slide. See, is there any need for TPN? Say most of the people, we don't practice TPN. Even in institute like ICH, it is not often practiced. Why is there any difficulty in practicing, or too much of mathematics has to be done, or too much worried about the complications, or too much worried about whether I can go for central vein or peripheral vein? So many things are there. But it is very easy to start TPN even by even in peripheral vein. So first of all, what is the need for TPN? See, what is this in utero feeding is equal to ex utero feeding? See, you all know that the fetus is growing in a superb way in the intrauterine period up to 9 months or 10 months, then they come out. So during the in utero period, the fetus is growing in such a way that the same sort of in utero growth we should give outside also. For example, I will tell you, when the baby is born, just before the birth, the baby used to drink around 400 to 500 ml of amniotic fluid as feeding. When they are born, we should again give the same amount of feeding the baby should have after the birth. That's why this colostrum is becoming very important. This colostrum, even though it is 3 ml or 4 ml in one feed, it's almost equal to the 300 to 400 ml of amniotic fluid in all the contents. That's why we always start with colostrum. So whether the TPN is better than enteral feed, not at all. Enteral feed is a must. It may be either in the form of orogastric or in the form of orojejunal. When I say orojejunal, you can extend from the xiphisternum to the axillary. That's called orojejunal. Who are all the babies you can give orojejunal? Clefted babies can be given orojejunal. Babies with the increased GERD can be given orojejunal. Baby who has got a delayed gastric emptying can be tried orojejunal. But there are certain conditions where this orogastric or orojejunal cannot be practiced. In those situations, I think we should consider TPN. So that means to match the feeding, there are a lot of evidence why you should give TPN also. The evidence shows that if you are not practicing TPN in extreme preterm babies or very low birth weight babies, the cellular growth is vastly affected, leading to poor growth and poor neurodevelopmental outcome in future. And some of the evidences shows that there is decreased cellular growth in cardiac status, in pancreas, and renal system also. That means TPN is here to say when I am not able to start enteral feed. Next slide, sir. See, what are all the indications for total parental nutrition? See, any baby below 1 kg or any baby below 26 weeks or 28 weeks or 24 weeks, the day one TPN has to be started, no doubt about it. And there are babies who got a lot of surgical issues in the form of, say, tracheoesophageal fistula, ileal atresia, general atresia, malnutrition, short bowel syndrome. Those situations also you should start. Sometimes you may be in the state of a child having a fulminant sepsis, where instead of giving fluid, shall we go for total parental nutrition to give adequate energy, adequate protein, adequate fat for the baby? Yes, you can practice. So that means, in simple one way, I say, when the gut is not all right, you start TPN. When the gut is all right, you can start giving enteral feeds. So there are certain indications for TPN like this. So TPN, sometimes it may be short term, say maybe 3 days or 7 days. Sometimes it may be 14 days. Sometimes it goes for 2 months and 3 months. So depending upon the clinical conditions, it may be varying also. Next slide, sir. So now in the beginning, I was telling why many people are not practicing PTN. Because everybody is worried about the central line, whether to go for central line for small babies. Yes, central line is the norm for TPN. At the same time, we can use peripheral line also. But when you are using peripheral line, all your constant, you are not able to reach the maximum. For example, dextrose can be given up to 12.5%, not more than that. Lipid can be given up to 3 gram per kg, not more than that. Protein amino acids can be given 3.5 gram per kg, not more than that. So that means there are certain limitations while using the peripheral line. But when you are targeting the district headquarters hospitals or many hospitals where the SNCUs are there, where the 1 kg baby is there, where the family is not in position to shift to the tertiary care center, I think those situations you should go for. Even peripheral vein, nothing wrong in it. In fact, Even umbilical vein catheter also you can do TPN, but not more than 14 days because of the fear of the complications. And PICC lines also, peripherally inserted central catheter also can be used for TPN. That means there's no need that central line should be there. You can give peripheral line, you can leave PICC line, you can use umbilical line for 14 days. So that is not a problem now. Next problem we are worried about is mixing the fluid also. So mixing the fluid, I will always say it's always Dasavadara, that is 10 avatars, something like that. You have got 10 constituents to be mixed in TPN, like protein, carbohydrate, lipid, sodium, potassium, calcium, trace elements. Sometimes you use heparin, sometimes you use insulin, and sometimes you give magnesium also. I always say this Dasavadaram, like 10 constituents to be used for TPN. So mixing the fluid also is a problem, many people. For that, you need what is called laminar flow, which cost around 5 lakhs only. Under the laminar flow, you can easily mix all these fluids. Third point, many people are worried how to give lipid. Is it safe to give lipid infusion? That is also that point that I will clarify when I talk about the lipid. Then fourth point, what sort of catheters useful? Whether you should go for Brovia catheter or go for Celastic catheter. I think now Celastic catheter has taken over the Brovia catheter, where you can easily use Celastic catheter. It stays for a long time, so TPN can be safe. So catheter-induced sepsis will come down when you start using the Celastic catheter also. That means let us forget all those problems. Let us concentrate how to improve the optimal growth of the extreme preterm and the VLBW babies. That means whether it is central or peripheral or umbilical, you can use any line to start TPN. Next slide, sir. So now let me go. So what are all the evidence? Let me go. I already told you extreme preterm and very low birth weight babies to be started. See, every day the baby loses protein, especially those babies who are below 28 weeks of gestation or below 1 kg. 1.5 gram per kg of protein is being lost compared to the term baby, which lost around 0.7 gram per kg. That means you have to compensate the loss of the protein by giving amino acids. That's why this protein amino acids can be practiced even day one of life. A lot of evidences have shown that giving adequate amino acid, even though there is a protein loss is there, still it is matching up those things. So I will go. So there are some amino acids what started with 0.5 gram per kg or 1 gram per kg. Now the recommendations are you can go even up to 2.5 to 3 gram per kg on day one of life. That is matching the loss of the protein what the fetus is having. But I already told you, if you want to have a very good cellular growth, I think we should go for a TPN. What are the next slides? Now let us see first how we can go for one by one. Okay. Fluid requirement. The fluid requirement is very important. Either you can go for dehydration or you can go for over fluid and going for pulmonary edema also. So you have to exactly calculate the fluid and give to the baby. It is like what we follow the routine formulas, no? For term baby, 60 to 80 ml per kg. For preterm, 100 ml per kg. For extreme preterm, you can go up to 120 ml per kg requirement. And whenever you are giving TPN, you total the fluid requirement. For example, I'm giving for 1.5 kg baby, I'm giving 150 ml. I'm going to give some ampicillin, gentamicin. I have to subtract the antibiotics and see to that I'm giving at least 110 ml of TPN, not more than that. And similarly, energy, the calorie is very much needed because the calorie is, see, for each and everything. Suppose the baby has got a lot of problem while giving TP and you have to give extra calories also. Suppose the child has got a cardiac problem, you want to improve the myocardial contraction, give 10% extra calories also. So normally we fix 80 to 80 kilocalories per kg for the term child when they are in need of TPN because of surgical issues. Or extreme preterm, we can go up to 100 to 120 kilocalories per kg. When I talk about calories, how we are going to reach this calorie? See, this is a take-home message. Suppose I am giving dextrose, 10% dextrose. That means 1 gram will give 3.4 calories. 3.4 calories per kg. Suppose I am using lipid. 1 gram lipid will give you 9 kilocalories per kg. Why I am saying this? This energy, the calorie should be met 50% from the carbohydrate, 35% from the fat, and 15 from the protein, because we need a protein accretion for the growth. So see to that the calories you are meeting out is mainly from the dextrose and mainly from the lipid and little bit from the carbohydrate and a little bit from the protein. Okay. Next slide, sir. So let us go to the proteins. Okay. First of all, I told you we can give protein in the form of amino acids. Amino acids, at present, we have 10% solutions are available mostly. Sometimes you would have seen the adult also using amino acids that is called 20%. So you are not supposed to use those adult amino acids. We should always use the newborn or pediatric amino acids, which is 10% solution. That means it has got 10 grams of amino acid. They are in the name of aminovin and aminosin. And these amino acids has contain all essential amino acids except glutamine and cysteine. The glutamine and cysteine will not be there. So glutamine is such an important neurotransmitter, why it has been missed in amino acids. So a lot of studies went on there, whether why glutamine can be given parenterally if the amino acids did not contain glutamine. So finally, all those studies showed that by giving separate glutamine, there is no improvement in the optimal growth of the baby, while seeing the control where with is no glutamine also. So there is no need for glutamine. And the study also showed that by giving glutamine, it is not preventing the baby for going any sepsis or necrotizing enterocolitis or any other issues. So the final recommendations is that you use amino acid even without glutamine, it is fine. But cysteine, whether cysteine is important or not. Cysteine also is not there in many amino acid solutions, but cysteine has to be used because cysteine has the tendency to reduce the pH load. When the pH load is coming down, I think the protein and the fat accretion is really good. And more importantly, it improves the solubility of the calcium and phosphate also. That means we are going to give calcium, phosphate, lipid, protein. That means cysteine has to be given maybe in the form of 3 milligram per kg. You can use cysteine as a separate solution that can be given. So amino acids always in the beginning, I told you, there are evidences to show that you can start from 2 to 3 gram per kg. No issue in that. And you can step by increases by 0.5 and 0.5. Whenever we are practicing total parental nutrition, I think we should think of 3 phases. Zero phase, today I am starting. Transition phase, I am increasing everything step by step. Growing phase, I have reached the level where I'm going to maintain this total this one and I'll see to the growth whether the child is gaining a growth. So that means whenever you start with 1.5 or 2 gram or whatever it is, you can step by step increase every day to reach the maximum. I was telling. So what is the ideal thing then regarding the protein amino acid? You can go up to 3.5 gram, 4 gram per kg based on the child's need. More extreme the babies, more protein is needed. Less extreme the babies, less protein is needed. So start with 2 gram per kg, increase by 0.5, reach 3.5 or 4 gram per kg. Whenever you are using amino acid, the more important thing in amino acid is many people are worried when I used more protein, the urea creatinine will go very high. At one point of time, I have to stop protein. But many studies have shown that it has got nothing to do with the urea creatinine. The increase in urea creatinine is more towards because of the fluid management rather than the protein management. But still, it is worth to investigate for urea creatinine every week whether I am in right line or my urea creatinine is increasing or not. But there is no direct evidence to show that amino acid is the culprit for increasing the urea creatinine. Next slide, sir. Next, we'll go to the carbohydrates. So carbohydrates, we are always going to use 10% dextrose only. But if the baby is very premature, maybe 800 grams, 700 grams, we may be using the 5% dextrose because very premature babies need more fluid. That means you can go for 5% dextrose also. So in carbohydrate utilization, what is our aim? See, our aim is to provide adequate carbohydrate, not more carbohydrate. When I give more carbohydrate, there is a chance of glycogen deposition that leads to a lot of fat accumulations also is there. So more carbohydrate may not be needed. Sometimes if more carbohydrate is there, you may be inclined to use insulin. Whether any evidence shows that insulin could be utilized. So I think as far as possible, insulin utilization has to be avoided. Because insulin, when we go for high carbohydrate and you use insulin, the chance of lactic acidosis can come. Point number two, the insulin is more of increasing the somatic growth rather than the hexagrammar and length. So these are all the situation insulin should be avoided. That means what is your aim? My aim is the blood sugar should not go below 40 and the blood sugar should not go above 150. Suppose there is a persistently high level of 150, 180, 110 or 200, those situations may be I am compelled to use insulin 0.05 units per kg subcutaneously. So that means evidences and studies have shown that starting the glucose infusion rate of 4 to 6 mg per kg is always good. Whenever you start TPN in the pediatric age group, you go for 4 mg per kg. When you start in the neonatal premature group, you go for 6 mg per kg. This is the pressure. Most of the PGs are worried calculating this total glucose needed and other things also. Because our aim is to have per day 13 to 15 gram per kg of this one glucose for the children. So when I go for 6 to 8 mg per kg, there is a simple formula I used to tell my postgraduates, the rule of thumb. That is 1 mg per kg per minute is equal to 0.6 ml per kg per hour. This is the rule of thumb. That means when I give 6 mg, it is 3.6. 7 means 4.2. 8 means 4.8. 9 means 5.4. 10 means 6. 11 means 6.6. 12 means 7.2 ml. I will not go beyond 12 mg per kg per minute of this one. So that means you start carbohydrate, especially 10% dextrose in the range of 6 mg per kg per minute. That is equal to 3.6 ml per kg per hour. Then maybe still you want to maintain a good glucose, the child needs more energy, you can increase from 6 to 8, 8 to 10, 10 to 12, don't go beyond 12 and don't go beyond 150 milligram. There are situations at 8 mg per kg minute, you are reaching 140, continue with the 8 mg per kg per maintenance so that is good enough for the children to have a adequate storage of glucose apart from the energy. So the rule of thumb, this rule of thumb will apply only for 10% dextrose, not for any other solution. 1 mg per kg per minute is equal to 0.6 ml per kg per hour. When I am using carbohydrates, I am going to do either at least BD examination of the blood glucose level, morning and the evening, what is happening, because TPN is a 24-hour solution. So morning and evening, what is the BD glucose? I want to look into it and adjust it accordingly. So the evidence that shows no need of insulin to control the hyperglycemia. You control the fluid, control the infusion rate, your hyperglycemia may not come because insulin is not very good. It increases the somatic growth, it causes lactic acidosis, but at the same time, when you are going beyond 150 milligram per kg, 150 milligram of blood glucose per day, and it is persistently there for 2-3 days, then you are compelled to use insulin there. Next slide, sir. Lipids. Now we have seen protein, we have seen carbohydrate. These are all the major macronutrients. These are the three things which is going to change every day. But other things are not going to change. They are going to be the constant one. So in the lipid, see many people, they don't use lipid for the fear of cholestasis, for the fear of PNAD, that is parenteral nutrition associated liver disease. Many people, they are worried because of using lipids. Somebody is very worried about fat embolism also. And these lipids cannot be mixed with all together also. That is also one of the reasons, because these lipids tend to go photooxidation and become hyperoxides also. So that means you have to protect the lipid from lights also. So these are all the issues many people are, you're not using lipid. When you are not using lipid, it is called partial parental nutrition. But lipid, even from day one of life, has to be used in babies. Otherwise, you cannot attain a somatic growth. So lipid has to be given, because if you don't use lipid for 3 days, the child, the extreme preterm will land up with essential fatty acid deficiency. So it is always better to start lipid, not in the form of protein, say 3 gram per kg. You can start 1.5 gram per kg on day one of life, then increase by 0.5, 0.5, 0.5 and reach up to 3 gram per kg. Lipid can be utilized. When I start talking about the lipid, whether to use 10% or 20% phospholipids, it's always better to use 20% phospholipids, which contain soya oil, soy flour oil, sunflower oil, something like that. While using lipid, there are evidences which shows that there are 3 generations of lipids are there. First generation intralipid is called available as intralipid, second generation lipid, and third generation lipid. The first generation is the intralipid, which is mainly a long chain fatty acid, and it is the culprit for producing phenol, that is parental nutrition associated liver disease. When I say phenol, initially there may be increase. See, it always goes step by step. Initially, cellular problem will be there, then canalicular problem will be there, then bile duct proliferation will be there, and finally land up to liver failure. So initially, you may be seeing an increase in serum bilirubin, then increase in the enzyme, then it becomes a cholestasis, then it becomes go for failure. So long chain fatty acids tend to produce phenol, tend to produce cholestasis. That's why this intralipid many people are afraid to use, but it is currently available everywhere. Many people are using it. That means, are you putting the child for phenol? No. That means when you are using first generation intralipid in the form of liposin, see to that how early you are weaning from the TPN and how early you are going to start the enteral feeds. That is very important. That is the only way you can stop phenol. Other second generation intralipid, that's very good, where 50% is long chain and 50% is medium chain. This medium chain triglycerides can be effectively utilized, but unfortunately, it is not available many in the market and many people are not using it. Now, the current research is going on third generation, what they call, it's called SMOF, SMOF. That is so S for soya oil, MO medium chain triglyceride, O for olive oil, and F for fish oil. So SMOF, SMOF. This fish oil, they see that it is not causing any evidence of any sepsis, or it is not causing phenol, it is not in liver disease. I think it should be the current one for recommended, but not many people are using it. But this is the one, lot of research is going on. So lipid should be started 1.5 gram per kg, increase by 0.5, 0.5 every day, go up to 3.5. More importantly, when you are mixing the lipid, see, you are not supposed to mix the lipid in the carbohydrate and protein syringe. You should have another syringe to take the lipid where multivitamin can be added. That doesn't cause any problem. That means the 2 syringes, when you put it there, at the infusion site, I think both the fluids will mix and go. So when you are putting a line for lipid along with multivitamin infusion, since the lipid used to undergo for photooxidation and gets corrected into hydroperoxides, better to cover the lipid with aluminum foil till it reaches the infusion site, where you use a 3-way catheter so that through one way amino acid proteins and other things will grow, the other way the lipid and MBA will be go. So whenever you are using lipid, don't forget to measure serum cholesterol and serum triglyceride. They should not cross more than 200. So every week or every maybe the initial week, 3 times per week, then after that every week you can measure. In some situations in abroad, what they say, there is a tendency to go for more triglycerides and more cholesterol. They used to give lipid as cyclical lipid, that is Monday, Wednesday, Friday, and Tuesday they don't give. This is called cyclical TPN, where the lipid is used in between one day after another day. But lipase is a must for the baby to have a essential fatty acids. Go to the next slides. Sodium. So sodium, even though babies, there is no need for sodium in the first 2-3 days because of the transepidermal loss of water. When the water is lost more and you give more sodium, there is more chance of going for hypernatremia. So that means the initial first 3 days, sodium may be given in the minimal quantity, say 1 to 2 milliequivalents per kg can be given. Once the baby reaches 7 days, then you can go for 3 to 5 milliequivalents per kg. Always use 0.9% sodium chloride, because chloride also has to be used along with the sodium, because chloride should not be left out. When you use 0.9% sodium, then you can give both sodium and chloride. Chloride also 3 milliequivalents per kg, sodium also 3 milliequivalents per kg. That solves the problem. But whenever you are giving a minimal fluid, that is, for example, day 1 and day 2, day 3, where not much fluid is there, then you may be going for 0.9% NaCl. Sometimes you may be in situation where the protein and lipid will be giving more. In that situation, you cannot go for overloading the child. At that situation, you may use 3% normal saline. Imagine 3% normal saline, their sodium is 514 milliequivalents per liter, and this one is 154 milliequivalents per liter. So rarely you may be in position to use 3% normal saline, but commonly always use 0.9% normal saline, 3 to 5 milliequivalents of sodium per kg. Potassium also 1 to 2 milli, chloride also 3 milliequivalents per kg. That will solve the problem. Next slide, sir. Potassium. So potassium, day 1 or day 2, you are not supposed to use. You have to assess whether the child has got positive urine, whether the renal function is fine. Then I am ready to use potassium. So potassium, KCl, 2 to 3 milliequivalents per liter can be used. Don't use on the first day. Similarly, I say you, when you use sodium, chloride, potassium, weekly thrice you should see the electrolytes, whether you are on board, whether the electrolytes is being maintained correctly or not. Okay, next slide. Calcium and magnesium. Is it very important to use calcium? Yes, calcium and magnesium, of course, you can include phosphorus also in that, because calcium usually on day 1, you can use 45 to 60 milligram. Then from day 2, you can go to 60 to 80 milligram. And phosphorus, you can go for, say, 40 to 60 milligram, you can maintain with 60 milligram. The idea of giving calcium gluconate and also phosphorus is to maintain a ratio of 1.7:1, so that effective mineralization can take place in the premature baby. Otherwise, they may go for osteopenia or prematurity also. So calcium and magnesium, calcium and phosphate can be given in the same ratio of 1.7:1 ratio. You can use the calcium gluconate. Generally, we use, when I say 60, it almost come to 1.5 to 2 millimole per kilogram. So you can take calcium gluconate and use slowly, and along with this one also phosphate. Magnesium is one of the trace element to be must used in those babies, because we have magnesium sulfate. Our obstetric colleagues are using a lot of magnesium sulfate. You can use that magnesium sulfate. Generally, I recommend 0.3 ml per kg or 3 milligram per kg is very essential in giving the magnesium. Right. Next slide. Trace element. So trace element, whether you should give trace element to these babies. See, whether you are going to give trace elements are not very essential up to 15 days of postnatal life. But there are 2 trace elements are very much essential on day 1 of life. That is, one is the zinc and the other one is the selenium. Because suppose I want to use trace element like copper and manganese. See to that the child did not have penile or cholestasis, then you are not supposed to use copper and manganese. Similarly, when the child has got a renal dysfunction with elevated urea and creatine level, you are not supposed to use chromium and selenium. Otherwise, the liver is fine, the kidney is fine, then you are entitled to use trace elements. In fact, abroad, trace element solutions are available containing everything like chromium, iodine, manganese, selenium, and copper. These are all the basic requirement of trace elements for the TPN in every preterm babies. For PGs to easily remember, I will put it like this: 0.2 chromium, 1 is iodine, 1 is manganese, 2 is selenium, 20 is copper, and 250 is zinc. Iron, no need to give in the initial period, but when I am going to continue TPN for more than 2 months, iron has to be introduced. Otherwise, there's no role for iron in the TPN. And similarly, when I start taking zinc 250, it is the minimal requirement. You can go up to 400 microgram also. So easy to remember: 0.2, 1, 2, 20, 250. 0.2 is chromium, 1 is iodine, 1 is manganese, 2 is selenium, 20 is copper, and 250 is the zinc. So trace element has to be given. These are all the micronutrient child needs. Next slide. What about the others? Multivitamin infusion. Yes, multivitamin infusion, there is nothing called fat-soluble vitamins or water-soluble vitamins. There is no separate preparation available abroad or India. What we generally use the multivitamin infusion that can be used 1.5 ml per kg. Generally, we advise for extreme preterm below 1 kg, give 2 ml. Above 1 kg, you give 5 ml, something like that. But multivitamin infusion has to be given only along with the, I already told you, with the lipid. So there will not be any problem. Do not mix with others. So that separately 2 syringes will be there. 1 syringe will be transferring all these things. Other syringe will be giving the lipid and the multivitamin. Insulin, I already told you, prone to produce lactic acidosis, prone to go increase the somatic growth, but not linear growth. So head circumference length is not improving, but weight will be more. So these are all the reasons insulin has to be avoided. But if at all you use, There is a persistent elevation of hyperglycemia in spite of controlling your glucose infusion rate, say in the range of 8 or 10 mg per kg per minute. In that situation, you can go for insulin and 0.05 units per kg. Next slide. So these are also, we have already seen how these 10 components has been mixed. One is the, what I told is the, first of all, you calculate the fluid. Then you calculate the energy. I know I told you how much you are getting the energy, 50% from the carbohydrate, 35% from the fat, 50% from the carbohydrate, 35% fat, and 15% from the protein. We are not getting much energy from the protein because we need protein and fat accretion also. But there are certain complications I told you we are worried. Most important, I told you, catheter-induced sepsis. It may be due to bacterial infections or it may be due to fungal infections also. When I say bacterial infections, I think two bacteria you should always remember, Staph epidermidis and Staph aureus also. MRSA resistant Staph aureus can cause, and Staph epidermidis is the most common organism to cause catheter-induced sepsis. Regarding the fungal infections, Candida albicans or Malassezia buffer can be the two fungal infection can cause problem. That will be shown in the form of severe thrombocytopenia, pallor, and other things. But most importantly, some of the studies expecting these complications where a low-dose vancomycin can be given a trial. So many people have tried with the low-dose vancomycin, but final recommendations came no antibiotic just because you want to prevent the catheter-induced sepsis. Already we have discussed enough about the cholestasis and penile. So when you use fish oil lipid emulsions, cholestasis and penile is not in the picture. But when you use the currently available intralipid, that is the long chain fatty acid, it doesn't contain medium chain. It contains safflower oil, soya oil, sunflower oil. In those situations, I think these cholestasis and penile will come. So these are all, and apart from there are certain complications about thromboembolism. Whether you are mixing so many things together that may lead to thromboembolism or not, this is the worry for many people. There are some people who started giving heparin also, low dose heparin, whether it can be tried in these cases, whether they say, suppose you give 120 ml, 120 units of heparin can be mixed with the fluid to prevent thromboembolism. But current recommendations, heparin is not being advised for anything. So that means you need not worry about heparin, need not worry about the insulin. Insulin comes into picture when the hyperglycemia persists. So this means the complications, we are worried about cholestasis, penile, catheter-induced sepsis. With the advent of elastic catheter, with the advent of laminar flow, and you are going to follow the strict asepsis precautions, everything together can prevent catheter-induced sepsis, whether it's bacterial or fungal infections. And regarding cholestasis penile, presently we are using long-chain fatty acid, but still, how early you are discontinuing the TPN, how early you are starting the enteral feed, that decides about the fate of the cholestasis and penile. So our aim is not prolonged TPN. Our aim is to emergency. TPN is an emergency. I used to say that total parental nutrition, inhaled nitric oxide therapy, high frequency ventilators, they are all called L4 management, not L3. It goes beyond L3. That's what I used to say that in Tamil Nadu. But TPN, it is an emergency where I am not able to do anything. I can go for TPN. How early you come out of the TPN? There are some cases you can see 50% TPN and 50% minimal enteral nutrition can be started also, and we adjust accordingly. So our ultimate goal is to have at least the child should get minimum 13 to 15 gram of carbohydrate, 3.5 gram per kg of protein, and 3.5 kg per gram of lipid also. Next slide. Next slide. So now comes the monitoring. Okay, whenever I am using total parental nutrition, how I'm going to monitor these babies. See, monitoring should be you have to take daily weight and height, and the head circumference you can take weekly. I told you when you are giving carbohydrate, BD glucose has to be measured, and accordingly you have to adjust the glucose infusion rate. Electrolytes, initially in the first week, 3 times you should do sodium and potassium, urea, creatine, everything. In the first week, alternate day, then weekly you can do. Calcium you can weekly you can do. Cholesterols and triglycerides also, initially when you are using lipid emulsions, you use every alternate day, then you go for weekly, and liver enzymes also is weekly. So ultimately, finally, next slide. I think I'm stopping with this. So ultimately, finally, what I want to conclude now is total parental nutrition is easily practicable. That's why when you use sometimes, no, it should be all times. See, any baby below 1 kg in the Western countries, the initial treatment is TPN. So it has come to the fore that we should use TPN to increase the neurodevelopmental outcome to improve the optimal. In fact, one of the studies have shown that a 800-gram baby who was started with the TPN initially, a big study some people have done. What they have found that below 1 kg baby, 800 gram, 900 gram, 600 gram, you taught TPN, and they followed up the baby. At the 18th month, what they found that the Bailey's mental development scale is as good as any term infant because of the utilization of TPN below 1 kg. So nothing to be worried about TPN, no fear about TPN, no fear about the complication. It has to be practiced, can be given in central catheter, can be given in peripheral vein also. In peripheral vein, you cannot go beyond certain limits, and you can use PIC catheter. And for umbilical vein catheter also can be used in the first 14 days, not beyond that because of complication. So with that, I think I'm very clear about TPN to all of you. And any questions, then Sweta, I can answer for other questions.
Thank you so much. Excellent practical presentation.
Yeah.
Any questions, Kunal? I think postgraduate may be on the YouTube link.
Okay. So they may not, they cannot question, no? Something like that.
It's a YouTube link, they cannot question.
Yeah, they cannot question. I think the India should come out. See, still I'm not seeing many NICUs are not using TPN for the fear of complication, catheters, amount involved, laminar flow. I think the laminar flow is not only for TPN. I think each and every ward should have a laminar flow because every
Yes,
day
sir.
you are missing a half normal cell and you are taking KCl and putting into it. That means you are introducing some pyrogen into this. So I think better to have laminar flow in each and every. I used to tell my ICH, please buy for 5 lakhs for each and every one and put the laminar flow. Let the aseptic precautions comes even for normal fluid, not necessarily a TPN also.
True, sir. Sir, we have Dr. Shilayar madam with us.
Yes,
She is our advisor of NNF Gujarat.
Yeah.
Ma'am, would you like to say something? Sheila ma'am?
I made the slide very simple for the postgraduates. I don't want
Yes,
to do a
yes,
lot of
absolutely.
complications. I let them
No, no,
the
I
post
think
Absolutely, very
point. Yes, it was really a very nice talk, Dr. Srinivasan. I think
Yes,
there is an underlying fear
Yeah.
which slowly needs to be removed.
Correct.
And everybody has this in mind that it's too expensive, it causes more
Yeah.
complications, it
Yeah.
has more. And probably currently what we need is for max 10 days. By that time, we all believe in aggressive enteral feeding.
Exactly.
Most of us have EBM available. So it's a period of around max 2 weeks. Other than that, we don't need this. And I think
That's what
slowly maybe we'll get there.
That's what I'm highlighting, madam. When we are not using protein and lipid from the first day,
Yeah.
child lands up with essential fatty acid deficiency by third day. Similarly, protein accretion is not the the three important organs. This is behind our eyes. We are not seeing it, but it is happening. Pancreas is affected. Renal system is affected. Cardiac system is affected. The cellular growth. There are a lot of evidences to show that also. So I think it should be practiced. As you said, 5 days or 3 days. So there are a lot of guidelines also. For 1,000, below 1,000, you start from day one. For 1,000 to 1,500, if the 3 days you are not able to reach 50% of the calories, you start using TPN. Something like that is there.
No, I mean, prolonged for weeks other than surgical cases, a very prolonged TPN, most of the time not required. So,
Madam, one point I want to highlight here is in ICH, my experience. I always admire the cardiothoracic surgeon and the pediatric surgeons. They are the person, they are really bold. For doing mal rotation on the third day, they will start enteral feed because they say that my intestine will undergo atrophy. They are the boldest person to start enteral feed on the third day. where my neonatologists and pediatricians are not stopping. That I have seen through my eyes also. I used to appreciate the surgeons always. They are the bold person to start enteral feeds as early as possible.
True.
Sir, there is
There is a question. Yes, Kunal, go ahead.
is there any advantage of intralipid 10 over SMOF lipid, as few needs change over to intralipid from SMOF lipid when fat requirement extended for more than couple of weeks?
Yeah, actually, as per the requirement of lipids, there is no difference between first generation intralipid and third generation SMOF. Only for the fear of complication, evidences has shown that when you use fish oil, olive oil involving SMOF, there is very less occurrence of penile cholestasis. So the next generation, I think we should go for a fish oil mixed lipid emulsions rather than the intralipid. But as per the fat accretion or the growth, there's no difference between these two. Not much evidence is there. For fear of complications only, the third generation has come.
Kunal, can we wind up?
Yes.
There is question and
No, ma'am, there are no further questions. So, okay.
Because PGs, why there is no further questions? Because PGs always they scratch their heads when you talk about TPM. Because they are getting confused. Is it a theory subject or a practical subject? Because if big institutes are not giving importance to TPM. Leave alone TPM. I am not seeing in ICH, even in pediatric intensive care units, up to 10 days, they are not starting enteral feed for the sick. That is not correct also, because nutrition is always in the back seat compared to the intensive management. Dopamine, adrenaline, noradrenaline comes first, and nutrition comes last. But I always say that 40 to 45% of the PICU outcome is determined by the nutrition, not by anybody.
true. Well said, sir.
Yes, sir. Thank you so much, Srinivasan sir, for the
Thank you, sir.
excellent talk. It is a high time when everybody should be start using TPN in their NICUs. As this presentation will be seen by much more people when we will be posting this on our YouTube link also.
I'm coming.
This lecture will be seen by many of the PG students also. So it is a very important message by sir that everybody should be giving TPN, and enteral nutrition should be also an aggressive part in your NICU management. So thank you so much, sir, for this wonderful message. Thank you, Shwetal ma'am, for joining us and guiding us. Thank you, Sheila Iyer ma'am, for giving the words of wisdom. And thank you, Dr. Vaibhav Patel for joining. He's our EB member. Thank you so much, Monish sir, for excellently moderating this session. Thank you so much, sir. And last but not the least, I'd like to thank ClearNet, Ritu, for seamlessly conducting this session. Thank you all. With this, we can conclude the session. Thank you.
Thank you.
Thank you so much. Thank you, sir.
Thank you, sir. Thank you.
Thank you, everyone. Thank you, dear doctors, for sharing your valuable insights, and hoping to meet you again in another interactive session in the near future. And wish you all a very warm wishes of the Ram Navami. Thank you. Stay healthy and safe. Thank you. Goodbye.